Hi everyone, so today we're going to talk about alterations in cardiovascular function. So I want to just gently touch upon some of the elements of the cardiovascular system and what they're supposed to be doing. So when we're talking about our vasculature, just gentle reminder, the main function two will focus on your arteries and veins. Arteries are going away from the heart and veins towards the heart. Arteries are going to be under higher pressure blood in them. Veins are a low pressure system. Veins also contain valves that arteries do not have, and those valves are in place to prevent backflow. So that we have unidirectional flow in our circulatory system. And that is through the arteries, through the heart, through the veins, through the capillary beds. Everything is moving in one way. It's a one-way street. In addition, in your heart, we also have heart valves. Again, same purpose is to prevent backflow. Okay, so the veins are, both veins and your heart have valves in place to ensure that blood is always flowing unidirectionally, one way. Okay, so we're going to start off by talking about some disorders associated with your veins. One in particular, we're going to talk about varicose veins. Okay, so this is a vein in which blood has pooled, and that's usually due to the fact that the valve has become a bit distended. Okay, so if the valve is distended and kind of sags, for lack of a better word, so to speak, then blood can pool in the area where the valve is distended. So this can occur for a couple of reasons. One, it could occur because of injury, or two, just gradual distension with age. And again, in the lower extremities, you're going to have gravity just kind of pulling the blood down towards your feet. There's no additional pump in your foot to push it back. So again, if you had distension of the valves, blood is going to pool there pretty quickly. Some of the risk factors associated with varicose veins would be things like age, family history, if there's a predisposition to developing varicose veins. Someone who's had a DVT is at risk. Obesity, an individual who's obese is at risk for developing varicose veins. Females tend to develop them more often than males. Sometimes you'll see pregnant women develop them because of the sudden onset of weight gain associated with the pregnancy. So over time, what can happen to someone who's got varicose veins is they can have venous insufficiency. And what will happen long-term, or could happen long-term, is you'll have a decreased rate of venous return. So that's a decrease in the rate that the blood should be flowing back through the veins back toward the heart, and that can put a strain in terms of cardiac function. Some of the signs with varicose veins, you might get some localized edema around the area of the vein in the lower extremities. Sometimes you get hyperpigmentation of the skin. And that's due to the pooling of blood in that area. And sometimes people are subject to static ulcers, which can put them at risk for infection. And again, this is because of change in the skin integrity around the area of the distended vein. The treatment for varicose veins, there's a variety of treatments. There are some surgical options. So, for example, there's an ablation procedure that can be done that can remove the damaged part of the vein. Elevation, obviously, to increase blood flow back to the heart, and compression stockings. And again, the compression stockings are doing exactly what they say. Okay, so they're going to compress the muscles around that vein to try to increase the rate of venous return and bring more blood past the valve that's distended back towards the heart. Okay? All right. If someone has a varicose vein in their anal canal, that's a hemorrhoid. So, hypertension. All right, so this is really an issue connected to arterial flow. So we're going to start by talking about hypertension, and then we'll talk a little bit about hypotension. So what does hypertension mean? It means that you have an increase, and this is a consistent elevation, meaning if you are exercising, your blood pressure will go up in response to the exertion of that particular exercise that you're doing. But if it's a consistent elevation in blood pressure, then it's classified that you have hypertension. It will be an arterial blood pressure. So remember, when we get blood pressure assessed by a physician, what they're looking at is 2 data points. Okay, your systolic pressure, or the pressure generated during systole, which is the period of heart contraction, over diastolic pressure, which is the pressure generating during diastole, which is the part of the time when the heart is in ventricular relaxation and filling. All right, so we get a number. I'm just going to use 120 over 80. So this is telling the pressure that's generating during systole over the pressure that's generated during diastole. If this goes to be up to 140, or if this, if this goes up to 90, then we can say that our patient has hypertension. Okay, so if we see a systolic pressure that's greater than 140 and it's consistent, or diastolic pressure that's greater than 90 and it's consistent, then we would say that we have an individual that has hypertension. So there are lots of risk factors associated with hypertension. Some of them are classified as modifiable risk, and some of them are classified as non-modifiable risk. If it's a non-modifiable risk, that means exactly what it says. There's nothing you can do to modify it. If it's a modifiable risk, that means you can do something potentially to modify or control the level of risk. So for example, something that's non-modifiable would be your age, family history, race. Okay, these are non-modifiable risks. Gender. And then if something is modifiable, that would be something, for example, like diet. You can modify your diet. You can modify your level of exercise. If you're smoking, you can quit smoking. Okay, so obesity is a modifiable risk for hypertension. So we all kind of hear the diet that we should be eating, right? More fruits and vegetables, more complex grains, fewer processed sugars, right? Decrease your level of alcohol intake, your saturated fat intake. Okay, those are modifiable things that you can do to improve your diet, improve your health, and of course reduce your risk for developing hypertension. So oftentimes someone who is hypertensive is asymptomatic. They don't have any symptoms. However, sometimes people can have symptoms associated with high blood pressure, headaches, for example, change in pallor, but oftentimes people have no symptoms. If left untreated, the issue with hypertension is it can cause significant damage to the kidneys. Okay, so it can cause kidney damage if left completely untreated. It also can put you at risk for a heart attack and for a stroke. So it's certainly something that should be addressed, okay, which is why when you go to the physician, because it can be asymptomatic, one of the first things they do is take your pulse, take your pressure, right, to try to assess those things kind of quickly, and it gives you a few different data points without really any invasive techniques. Okay, so how do we treat it? And again, we talked about kidney damage when we talked about renal issues, and it can lead to kidney failure long term. So we have a couple of different treatment options for high blood pressure. And if you talk to 3 different hypertensive patients, they might be on 3 different treatments, okay? I would always recommend at the very top, lifestyle changes. And that's not a popular recommendation. Lifestyle changes are difficult, but I would always recommend to somebody, especially someone who has a pretty significant family history of hypertension, they want to make sure they're watching their diet, they're watching their alcohol intake, they quit smoking, and they start doing some movement, some sort of aerobic exercise a few times a week if possible. Okay, so the treatment for it is really going to depend on the severity, but can include things like diuretics, calcium channel blockers, Norvasc or amlodipine, which is a very commonly prescribed treatment for hypertension, as a calcium channel blocker, just as an example. You have angiotensin converting enzyme, ACE inhibitors. You have angiotensin receptor blockers. And these are really targeting the RAA system. This is just to name a few. So these are really the diuretic is really working by increasing fluid output, right? So if we reduce blood volume, we reduce blood pressure. Okay, calcium channel blocker is going to relax the smooth muscle layer, that tunica media around within the wall of your arteries. And if you relax, it'll vasodilate a little bit. So that's how that will relieve pressure by decreasing resistance to flow. These target the RAA system. And the effects of angiotensin, for example, which is a pretty potent vasoconstrictor, and then angiotensin converting enzyme inhibitors inhibit the conversion of angiotensin between angiotensin 1 and 2, and again is going to reduce the level of vasoconstriction. Okay? All right, so let's just talk quickly about kind of the opposite issue that I'm going to pick on specifically. When someone has hypotension, they have consistently low blood pressure. One issue associated with that is something called orthostatic hypotension, which means that someone has a decrease in blood pressure, so oversimplifying, upon standing. So this puts you at risk for falling. Okay? And then the injuries associated potentially with falling. Okay? You break a hip, knock yourself out, etc. You can have acute or chronic orthostatic hypotension. So it can be acute for a variety of reasons, including things like certain drugs. It's a side effect, starvation, physical exertion, dehydration. Okay, so you have decreased blood volume. Venous pooling. If someone's got blood pooling in their venous system, it's decreasing the rate of venous return. Remember, when you have low blood pressure, now when blood is pumped out of your heart, it has to fight gravity to go to your head. So then obviously, if someone has low blood pressure, you're not getting blood up to your head at the correct pressure. I'm not saying zero pressure, I'm saying at the correct pressure. And so because of that, you would feel dizziness and feel faint upon standing, right? You're changing your position on the earth, and your body can't accommodate for that change in the position, your position on the earth, and that change in gravitational pull. So if it's acute and, for example, it's due to something like low blood volume, maybe due to dehydration, then the treatment would be fluid. If it's starvation or extreme physical exhaustion, then those would be treated in a different way than this would be. Certain drugs that are vasodilators, the side effect can be that it decreases your blood pressure too much, so you'd want to modify the dose. Some chronic conditions are related to the endocrine system. For example, if you have a change, the little delta means change to either ADH or aldosterone. Those are two hormones that are both involved in controlling blood volume and blood pressure to some degree. If you had changes in those, that could lead to chronic orthostatic hypotension. Or certain neurological issues like Parkinson's. Because with Parkinson's patients, you're losing control in the peripheral system over some of your muscles, that could cause a change in the way that your blood pressure is controlled. Okay, again, signs and symptoms would be dizzy, possibly faint. Okay, blurred vision. So one of the ways you could combat it is to give a vasoconstrictor. If you were able to give someone a vasoconstrictor and kind of tighten up some, now instead of dilating, right, your arteries, now you would be constricting them and closing down that luminal space and increasing the resistance to flow a little bit. That's going to drive up pressure. If it was something like a change in aldosterone, let's say you had low aldosterone, you'd want to give it back. So sometimes the treatment can be mineralocorticoids. Okay, so we could give a vasoconstrictor. Again, then you have to watch pressure. Mineralocorticoids, the same thing. And then maybe we increase our fluid and salt intake. Again, there you're trying to drive up fluid volume and pressure. So it's really going to depend on what the root cause of it is in the first place as to how the treatment would pan out for different individual people. Okay, the last thing I want to talk about is an aneurysm. So most people know aneurysm. They connect it to an aortic aneurysm, so which is fine. That's okay. What is an aneurysm? It's when, I'm just going to draw a vessel. You have an outpocketing. Very often these occur in the thoracic or abdominal aorta because of just by the nature of the fact that that vessel, the blood inside of it, is under a tremendous amount of pressure that you can almost see it becoming a little bit distended, right? Risk factors for developing an aneurysm would include things like hypertension, inflammation, atherosclerosis, which we'll talk about in a few minutes. But another condition that is connected to this is something called Marfan syndrome. Marfan syndrome is a connective tissue disorder where you have weakness and a decrease in the production of collagen that can weaken vessels. And because you do have collagen fibers reinforcing the aorta, if you're not producing the appropriate amount of collagen in the correct form, then you can imagine the vessel wall would simply be weaker, and that actually can put you at risk for the aorta to burst. And obviously would be fatal. Okay, so Marfan syndrome, you're really changing the structure of the wall of the artery. Okay. All right. Sometimes just slight outpocketings are completely asymptomatic. Okay. Obviously, the aorta were to rupture, that's exceptionally dangerous. Okay, but you would have pain. If there was a rupture and a hypotension, you'd have a significant drop in blood pressure. Okay, and then obviously if you had an outpocketing, again, let's not go to the extreme of it rupturing, but it started to protrude out further. If it's running through, let's say the thoracic aorta, because it's going to now put pressure on other structures in that area, you would have things like potentially difficulty breathing or difficulty swallowing associated with that if there was some sort of pressure on the esophagus, for example. So early stages when someone has an aneurysm, you would have a decrease blood volume and blood pressure, of course, right? Because you've got, you want to reduce stress on the vessel. So initially, if someone has an outpocketing, we really want to pull back on the stress that vessel is under, and so we'd want to decrease volume and pressure. So we do treatments that would be connected with that. If you had something really that was starting to outpocket to the point that it was risking potentially bursting, then you would do a graft to try to reinforce the vessel wall. Okay, our next video is going to start with thrombus and embolus.